Okay, this is the third podcast in this series from the second dysrhythmia PowerPoint. We talked about AFib, now we're going to talk about A-flutter. They're very similar, however, there are some differences. There's only a single cell firing at a rapid rate, whereas in AFib there was multiple. This one only has a single cell firing. The rate is usually 200 to 350 per minute. And the P waves have a sawtooth appearance, like you see in this strip down here. Like you see in the strip. Looks like sawtooth. So we have one cell firing. And once again, the AV node controls the impulses. It will not allow every beat because it's way too rapid, but it'll allow some of them. Sometimes it's one beat for every 4 or one beat for every 3. It can vary. Causes, you usually see flutter in patients with CHF. Their atria, congestive heart failure, chronic heart failure, their atria has stretched from constant fluid overload, or somebody who's had atrial ischemia from an MI. So you're going to see this a lot in heart failure patients. So our treatment, digoxin moves to the front of the line because it's mostly heart failure patients you're going to see this. You're going to see metoprolol and diltiazem to try to control the rate, amiodarone, antiarrhythmic. Remember what I said about meds. So you're going to want to review digoxin, metoprolol, tartrate, diltiazem, amiodarone. You're going to want to familiarize yourself with these. Amiodarone is an antidysrhythmic. Cardioversion, if the meds aren't helping. Cardioversion sometimes works better than AFib because it's only one cell firing, but not always. A flutter is usually more likely to respond to any treatment more than AFib is. But basically the treatments are the same. It's just that digoxin moves to the front of the list because of it being in heart failure patients. So if we compare what AFib looks like to A-flutter, the bottom strip is AFib, the top strip is A-flutter. For a novice eye, you might say, well, this doesn't look all that different, but there is differences. These P waves, if you want to call them that, they're not even really discernible, really look like dull sawtooth, whereas this is just obviously no P waves and very irregular. A flutter tends to be a little more regular than AFib will be. So that ends the atrial dysrhythmias. We'll just talk a minute about junctional dysrhythmias. I will not put anything on an exam about junctional dysrhythmias, but you need to know the AV node can generate electrical impulses. If it does not receive a stimulus from the SA node or anything in the atrium, it's going to stimulate its own impulse. That rate is usually 40 to 60. It can't really go any higher than 60. This is usually a temporary situation, either due to some ischemia or to some swelling from surgery, and requires no treatment because it's basically temporary and short-lasting. However, if it doesn't go away or resolve on its own, the patient is going to need a pacemaker. Patients will lose their atrial kick, which is that amount of cardiac output of the blood coming from the atrium down to the ventricle, and that accounts for 15 to 35% of their total cardiac output. So it's really important to have that atria functioning. We're going to talk about AV blocks. I'm going to tell you that I'm not going to put strips of AV blocks on the exam, but you are going to have questions about AV blocks. Usually they'll describe their appearance, and you'll have to discern like what kind of treatment would happen for this. What happens with AV blocks is electrical impulses are either delayed or completely blocked at the AV node. The SA node functions normally, sends an impulse down to the AV node where it's delayed or blocked. Causes for this, anything that slows conduction, beta blockers, calcium channel blockers, and digoxin, and any kind of ischemia or necrosis in the ventricles from a previous MI, especially tissue that would be right near the AV node. There are 3 types of heart blocks. There's first degree, second degree, and third degree. Second degree has 2 types, type 1 and type 2. And we have a nickname for type 1. We call it Winky Bach because it was discovered by a doctor named Winky Bach. So in first degree, the impulse is just slowed through the AV node. There's a delay. All impulses reach the ventricles. Our PR interval is greater than 0.20 seconds. Now, if you look at this strip and do your step-by-step analyzing, the heart rate is 60. It is a regular rhythm. There is a P wave for every QRS. So you're starting to think, oh, this could be sinus rhythm. But then you measure your P wave, your PR interval, from here to about here, and it's a good 0.32 to 0.36, definitely greater than 0.220. So that's why it's important just to know how to count your intervals, or otherwise you would not be able to discern a sinus rhythm from a first degree block. What do we do to treat it? Maybe we have to adjust drug therapy. If they're on calcium channel blockers or beta blockers, they may need to be held. Treatment is usually not necessary for a first degree block. Usually we just monitor the patient, let the physician know, and just make sure that they don't go into a further degree of heart block. Then in second degree heart block, 2 types, type 1 or type 2. Type 1 is known as Winky Bach. There is an actual blockage of the impulse through the AV node, and it's occasional. So some impulses will go through and some don't. With type 1 or Winky Bach, what happens is the PR interval progressively lengthens until a QRS complex is dropped. If the patient becomes symptomatic, we will treat with atropine. If they're not symptomatic, once again, we monitor it to make sure they don't progress into a higher level block. So if we look at our PR intervals, this one is 0.16. This one is 0.28. This one is 0.32. Then we have a P wave and no QRS. And we just call this longer drop. And the saying is, longer drop, now we have a Winky Bach. Then if we go to type 2, this is the P wave. The PR intervals are consistent with every conducted QRS. They may be long, they may be prolonged, like this one's a 0.28, but it's consistent. What's not is that you'll have a P wave, a QRS, a P wave, no QRS. You might have a couple complexes, and then a P wave and no QRS. So some of these are totally blocked. You'll see lots of P waves without QRSs. So if you look at this strip, these lines would be where we would expect a QRS complex to fall. We have a PQRS, P nothing. PQRS, P wave, nothing. So what are we going to treat? We're going to treat atropine for severe bradycardia. They may need a temporary pacemaker till we figure out what's causing the heart block. It is possible at this point for the patient to go into a third-degree heart block. They need to be monitored very quickly or monitored very carefully because third-degree heart block can be lethal. So that leads us to third-degree heart block. Let's talk about that. Either called third-degree or complete. A long time ago, we used to call it AV dissociation because the atrial and ventricles aren't communicating. There is a dissociation between the two. SA node impulses are completely prevented from going through the AV node. So the AV node starts firing. So you have both the SA node and the AV node firing, but they're not coordinated. You have independent activity of each. You will see P waves at regular intervals, and the QRSs will just kind of fall where they may because there's no coordination. That impulse from the SA node's not getting to the AV node, and the AV node's firing on its own. So that's why it's dissociated or no coordination. And it really greatly decreases cardiac output. The patient may be very symptomatic due to bradycardia. Usually the causes of third-degree heart block are ischemia, degeneration of the conduction system, or surgical injury. And degeneration of the conduction system just means aging. You know, a 90-year-old, whether they're a good 90-year-old or not, they still have 90-year-old organs and conduction systems that wear out after time. It is life-threatening. Treatment is a pacemaker, and they will have a temporary pacemaker until they can get a permanent one. Now, if it's due to surgical injury and they're not sure if it's temporary or going to be temporary or permanent, temporary meaning just caused by edema from the surgery, they're going to give it a few days, see if that, once it has a chance for that edema to go down, and if the rhythm doesn't come back or improve, then they know that it's a permanent surgical injury, that some part of the conduction system got severed during surgery. Atropine does not work for this heart block. So you should not give atropine in third-degree heart block. It's a waste of a drug. It will not work on the AV node. This is what it looks like. And you're saying, okay, I'm not sure what I'm looking at, and that's fine because it takes trained eyes sometimes to discern a third-degree heart block. This one, believe it or not, is fairly obvious, but I've had some that I've really had to study to figure out that it was a third-degree heart block. Here you have a P wave, and you said, well, there's a QRS, but there's a P wave here and a P wave here, and this QRS kind of just falls wherever. This is actually a P wave, and if you would march out these P waves, they fall on regular intervals, meaning there's probably a P wave in this T wave, there's probably a P wave in this T wave, at the end of this T wave here. So the ventricles are firing independent of the P wave, of the atria. And then just something a little bit about a bundle branch block. This occurs in the ventricles. So there's a conduction delay or block in one of the two main bundles of His branches. There's a right bundle and a left bundle. The right bundle goes to the right ventricle, the left bundle goes to the left ventricle. This could be temporary or permanent. It could be temporary from edema and surgical injury. It could be permanent from an MI. This is commonly seen in patients with known diagnosed heart disease or an MI. What constitutes a bundle branch block is a widened QRS. Now, what could happen is the patient could need a pacemaker because if the conduction deteriorates in the ventricles, then you're not having any electrical activity going into the ventricles to help them contract. So any QRS complex that you measure that's greater than 0.1 0 is considered a bundle branch block. Once again, this is not something I'm going to test you on.